Hi doctors, welcome again. In previous module, we learned how ventilators work, and also we learned about few terminologies used commonly in ventilator sciences. In this module, we will learn two important pressures, peak pressure and Pplat, that is plateau pressure, and then a few basic modes. And also we will try to interpret the basic waveform also. Now let's discuss the two most important monitoring variables which provide lots of information about lung mechanics, the resistance and compliance. Here we will study a pressure time graph during a ventilator breath or mechanical breath of volume control mode. Airway pressure is plotted on y-axis against time in seconds on x-axis. Inspiration begins with inspiratory valve opening. As the inspiration continues and gas fills up the airway and alveoli, there will be rapid rise of airway pressure, which will reach the maximum value. The highest pressure during the inspiratory cycle of breath called PIP or peak inspiratory pressure or PP. Following this, both inspiratory valves and expiratory valves close and inspiratory flow ceases during an inspiratory pause. During inspiratory pause, pressures dissipates due to opening of slow alveoli and a lower pressure is attained, which is called Pplat or plateau pressure. This is a pressure which is very important to find out the lung compliance. We will understand about it in detail after some time. Now, following inspiratory pause, expiration starts with opening of exhalation valve. At the end of expiration, airway pressure reaches to minimum value and expiratory valve closes. Sometimes to know the plateau pressure, inspiratory hold maneuver is performed by pressing a button there for a few seconds. Peak pressure is the highest pressure during whole mechanical ventilatory cycle, and this reflects resistance to airflow in both airway and alveoli. PIP is typically 12 millimeter of mercury normally. So it follows that if there is a problem with the airways, the peak pressure will rise. Plateau pressure is the pressure that is applied by the mechanical ventilator to the small airways and alveoli. It reflects the pulmonary compliance. If the pulmonary compliance is poor, the plateau pressure will be higher. What are the examples? What are the respiratory situations where pulmonary compliance goes down? So all the pulmonary edemas where the fluid is accumulated inside the alveoli or outside the alveoli. It may be cardiogenic or non-cardiogenic pulmonary edema. These are the situations where the pulmonary compliance goes down. Okay, that means that a lung is not flexible. Okay, it is difficult to inflate the lung, and that is where your plateau pressure is increased. So if the plateau pressure is going up, it means that it is the lung which is getting stiffer. Okay, now we will understand the very important pressure, and that is the trans airway pressure. The trans airway pressure is the difference between the pressure at the airway opening and the pressure in the lung. Okay, so that is your trans airway pressure, which is actually a difference between the peak inspiratory pressure and plateau pressure. In case of high resistance in airway, higher trans airway pressure will be generated. So the gap between the peak pressure and Pplat will be widened. Okay, and that has to be monitored always when you are ventilating a patient. So there are various causes for high trans airway pressure. We will understand that later. Now here is the question for you guys. Once mechanical ventilation is established, which of the following suggests that intraluminal mass is present? So you look at this sagittal CT scan of thorax where you see this is the bronchus. Okay, here is a opacity, and that is probably a mass inside the lumen of one of the bronchi, main bronchi. Okay, so what is the problem then? How will it present? So will it present with elevated resistive pressure, or high net ventilation will be a problem, or there will be inappropriate tidal volume for the lung, or increased elastic pressure? So what should be the answer? So remember that the peak pressure is related to resistive pressure, and intraluminal mass will pose high resistance to flow. The answer is A, high resistive pressure. Pplat is related to elastance of lung and chest wall. So the answer is high resistive pressure. Observe the pressure time scalar below and answer the following question, and compare the P peak and Pplat in both situations. What is the different parameter here? So this is the question A and B. What is the problem? Observe the pressure time scalar here. So first observation here is that the peak is quite high, okay, about 40 centimeter of water. This is 40. The reason for high peak in scenario A could be due to resistive problem. Why? Because the difference of PIP and Pplat is what is determined by resistance in the airway. So it is quite widened, okay. And here peak pressures is the same, but there is increase in the Pplat, okay. So means the problem over here is in the alveoli. So this is the scenario B. Here the Pplat is increased, probably that is related to the problem with the lung compliance. Here the difference in the PIP and Pplat is narrow. So the problem is not a resistive one. The second scenario, the problem is in the lung or maybe the chest wall. Increased PIP with normal Pplat reflects increased airway resistance. So you have to reduce the airway resistance by doing suctioning, or check the ET tube position, use the bronchodilator, evaluate endotracheal tube patency and evaluate it for the obstruction. You can perform a bronchoscopy. Consider the kinked tube. Sometimes the tube may be bitten by the patient who is agitated, and suction, put a catheter in and see whether you are able to pass the catheter through the tube. If there is obstruction, you won't be able to pass it. And if there is mucus plug, you can suction it at the same time. And if there is no problem at all, then consider bronchospasm, always auscultate for that. Either you will hear rhonchi or you will not hear anything else. Okay, you won't hear at all. So that is your silent chest. Can plateau pressure be higher than peak? So some people might ask you. Yes, there is a scenario. This is the case report. In the pressure regulated mode of mechanical ventilation, plateau pressure can be higher than peak pressure if inspirative effort of the patient generate large tidal volume, and efforts of the patient generate large tidal volume at significantly negative pleural pressure. This is the case report which was published in Annals of American Thoracic Society. This is the case report where the patient generated high Pplat, okay, due to so much of negative pleural pressure. Now let's discuss another important concept of ventilator sciences, the phases of mechanical breath. The mechanical ventilator breath can be separated into two parts, inspiratory phase and expiratory phase. So there is a trigger which initiates the breath. It could be divided into two types of trigger, the patient trigger and machine trigger. Usually the machine trigger is always time trigger. A limit variable, so this is the limit variable, which represents the maximum value of a parameter which can be attained during the inspiratory phase of a mechanical breath. This does not end the inspiratory phase, okay? The limit will not end the inspiratory phase. That you should always keep in your mind. That is cycle which actually ends the breath. So at the end of inspiration, gas flow ceases and the breath is switched into exhalation, and this transition point from inspiratory phase to expiratory phase is termed as cycling. Cycling is change over from inspiration to expiration. Okay, and there is always some variable which actually does that. Usually it is a time. So usually the ventilators are time cycled. Sometimes they are volume of flow cycled. Sometimes they are flow cycled also, as in case of pressure support. Now let's discuss the types of breath delivered to the patient who is on mechanical ventilator. The breath could be purely mandatory, in which the ventilator takes part in either initiation or end of the breath, or it could be a spontaneous breath. Okay, where the start and end of inspirations are determined by the patient. The mandatory breath is called assisted breath when it is patient triggered. Okay, this is a subsection of mandatory breath where if the patient is triggering the breath, that is called assisted breath. Where in case of spontaneous, there is also one more subsection where the expiratory pressure is greater than baseline, and this kind of spontaneous breath is called supported breath, okay, or augmented breath. So usually the spontaneous breather can be supported if the pressure is provided to the breath to augment the tidal volume. So if you don't put the pressure here, or if you don't support the breath, the tidal volume of breath will not be achieved as desired. So these points will be more clear to you in the next slides. Now, here you can notice a drop of pressure from the baseline. This is the pressure time scalar. There's a drop here, and this is called patient trigger. Okay. In this, there is no drop in the pressure. This breath is time triggered or machine breath. So this is the difference. Now, what are the type of triggers I was selling? There may be a time trigger, pressure trigger, flow trigger, or neural trigger. I'm not going into detail of this because we have learned it already, I think. Now we should understand the trigger sensitivity. This is the change required to trigger the ventilator, change in some setting. So it could be flow or pressure. The higher the change required, lower will be the sensitivity of the ventilator. So there is an inverse relationship between the patient effort and sensitivity of the ventilator. So it means that ventilator is not able to understand whether the patient has actually triggered. That is a bad problem. That is a bad scenario where the patient is making effort, but it is unrecognized by the ventilator, okay, as a trigger. The trigger should be strong enough. Trigger should be strong enough, and ventilator should be sensitive enough to start the breath. If your sensitivity is not enough, the patient will suffer. Patient has to make more effort every time, and that will cause patient ventilator asynchrony. Now we will understand the limit of mechanical breath. A limit is a variable that represents the maximum value of which the ventilator can attain during the inspiratory phase of a mechanical breath. It remains at that level till changeover to expiration occurs. But remember that it will not end the inspiration, okay? There are three main limit variables in routine use: the pressure limit, flow limit, and volume limit. Remember that a time cannot be a limit variable, because in that case the breath would have to end. Okay, so that is important. The time is not a limit variable. Example of pressure limited mode of mechanical ventilation are PCV and PSV. Volume targeted ventilation are usually flow limited. Volume limited breath is more or less same. Where the volume limit is met, the inspiratory flow ceases, but the expiratory flow phase does not begin. That may be possible. So it means that the inspiratory pause will start. So that is what it means here. Okay. So once the flow desired tidal volume is reached, it will remain there. It will the expiration will not start. So the tidal volume will remain there for some time. Both inspiratory and expiratory valve will close. Expiration will not start, and that phase is called expiratory pause. And during that, you can measure the plateau pressure. That is your volume limited breath or volume targeted breath. Cycling is the changeover from inspiration to expiration. Cycling phase variables are in time, volume cycled in PR, time cycled in all modern control modes, volume cycled in PRVC mode, flow cycled in pressure support ventilation mode or volume support mode or PAV mode, and pressure cycled in older Bud Mark 8 ventilators, which are no longer used. Now let's discuss few basic mode of mechanical ventilation. As I have defined the mode in the previous module, the mode is the way the ventilator delivers a breath to the patient. It indicates the type of breath being delivered and how the breaths are triggered, controlled, and cycled. A mode may belong to one of the three categories: conventional ventilation modes, adaptive ventilation mode, and biphasic ventilation mode. But there is much more to know about the taxonomy of ventilator modes. There are three categories in invasive mode: conventional, hybrid, and advanced modes. Okay. In conventional mode, it can be continuous mandatory ventilation or control mandatory ventilation or assist control. Hybrid mode is the controlled or full mechanical breath uh, and unsupported breath, or you can say the spontaneous mode of mechanical ventilation. This is called hybrid mode, assembly mode. Okay, and advanced mode can have a lot of new generation modes like PRVC, ASV, PAV, APRV, now VAPS, etc. And then there are some mini modes described like ASV volume support and spontaneous blood pressure support. So now we will understand the CMV mode, that is continuous mandatory ventilation, which is the mode of mechanical ventilation in which the breaths are delivered based on preset variables. The breaths are purely mechanical or machine breath, which is time triggered. So here the breaths are started at a set interval, which is determined by your respiratory rate and I ratio. Okay, volume or pressure limited. The breaths are time triggered, and all breaths are mandatory. They are having preset frequencies by time, pressure, volume control, time triggered, volume of flow, pressure limited, and time cycled. Okay, so this is about the CMV mode. However, CMV mode is associated with profound diaphragm muscle dysfunction and atrophy. Therefore, it is no longer the preferred mode of mechanical ventilation. This mode is still used in the paralyzed patient or sedated patient in operation theater, and sometimes also in transport mechanical ventilation. Control modes are classified into volume control and pressure control. Fundamentally, in volume control, tidal volume and flow rate is set or fixed, and in pressure control mode, expiratory pressure is set or fixed. Okay, so we'll understand it better here. So sometimes in exams, you may be given these kinds of graphs, okay, to read or to interpret, and then they might ask you that which kind of mode it is. Okay, so you can see here, this mode is different, and here in the right side of this mode is different. So this is your square wave flow pattern. This is your decelerating flow pattern. Okay, in the pressure time scalar, this is your accelerating pressure to the maximum limit and decreasing. Here it is square wave form of pressure. So this is constant pressure. So it is a pressure control. This is also pressure control. Here the flow is constant. Okay, so that is your volume control. So this is the way you will be able to identify. So here is a table which enumerate the basic differences in the volume control and pressure control modes. As I said, tidal volume and expiratory flow are fixed or constant in volume control mode, and PIP, Pplat are changing according to the lung characteristics, that is the compliance. For example, in a stiff lung, for the same tidal volume, peak expiratory and Pplat will be higher compared to the normal lung. In pressure control mode, P expiratory is fixed, okay, PIP is fixed or set. And tidal volume of flow both will be variable and will depend upon the lung characteristics. So in case of a stiff lung, lower tidal volume will be achieved using similar expiratory pressure or, as compared to the normal lung. So the advantage of pressure control over volume control is that the chances of barotrauma are lesser. So the barotrauma is a injury to the lung fibers, okay, and lung parenchyma due to high pressures generated inside the respiratory system. So that is your barotrauma. So the chances of barotrauma are lesser when you are using the pressure control. So you are not allowing the pressure to go over a certain limit, okay, and the flow can be increased from ventilator according to patient demand. That is the second advantage, that the flow can be given higher, or it will be patient dependent. If the patient requires higher flow, the ventilator will give higher flow. If the patient requires less flow, the ventilator will give less flow. So that is totally user friendly. So flow is given or is provided by the ventilator in case of pressure control according to patient's demand. And also there's one more advantage, that it compensates for the leak. Whereas the volume control, there is no leak compensation. There is higher chances of barotrauma, and there is also patient ventilator asynchrony due to fixed flow rate. Okay, so you cannot give higher flow rate. A patient requires more flow rate, more flow demand is higher. The volume control probably is not a mode of choice. But the problem with the pressure control is that the volume delivered will be lesser if the patient lung is not compliant or it's not expanding much. Okay, so in that case, the trial volume will go down and down. So I can give you one example, beautiful example, that during the fluid resuscitation, if the patient develops pulmonary edema due to volume overload and the tidal volume delivered will be progressively decreasing and hypoventilation will develop. And due to this particular concern, volume control is always preferred mode by many intensivists in the world. So there is a difference, as I said in the previous slide, the difference between the pressure targeted or pressure control ventilation and volume targeted or volume control mechanical ventilation. In volume control, the flow will be square wave. In pressure control ventilation, the pressure will be square wave. Okay, so here the flow will be square wave, here the pressure will be square. This is the basic difference. We know that CMV is not a good mode. It is purely mandatory mode because it does not take patient effort to trigger the mechanical breath, because it is time triggered. Scientists have devised a better mode, which is standard of care nowadays. Almost in all ventilator models and the brands, it is available and all are using it. This is the assist control mode. So this is the assist control mode where there is a patient trigger. Okay, patient cooperation, patient's participation is required to trigger the ventilator. The limit is flow or volume in assist control, volume control, and pressure is the limit in case of AC or VC mode. Cycling will be as in CMB, either volume or time cycled. Now let's understand about the SIMV mode. Many people use it still. Synchronized intermittent mandatory ventilation. Synchronized intermittent mandatory ventilation. Here, two things are combined. Mandatory ventilation is still there. There is also a component of spontaneous breath, which is allowed, okay, inside the CMB, but between the two breaths. And then this spontaneous breath is allowed, but it is synchronized. Okay, that is also important. Means that suppose a ventilator is delivering a breath of at equal interval. Okay, suppose the patient wants to take a breath. So what will happen? The interval between the two breaths will be widened a little bit, and it will give some room or some time or some window to the patient to take the spontaneous breath. So that is the advantage. This ventilator mode will provide a set number of breaths, but a patient can trigger a spontaneous breath with volume determined by the patient effort. In other words, with this mode, the ventilator will deliver a mandatory or set number of breaths with a set volume, while at the same time allowing spontaneous breath. The advantage over assist control mode is that SIMV may improve the patient comfort and may limit the dynamic hyperinflation, which may occur where the set breath is delivered immediately after the patient's spontaneous effort. So there is spontaneous, breaths in between the control breath. That is the SIMV mode. So the SIMV mode was initially developed in 1970s as a method to wean the patient. Okay, this was the weaning mode, and for about 30 to 40 years, it actually ruled the world. Okay, inside ICU, everybody was using a SIMV mode, but later the drawbacks of SIMV mode were recognized. They found, this is the international practice variation, that now only in about 6% of ICU, maximum 6% of ICU, SIMV is being used for weaning. Okay, and studies have shown that SIMV is least efficient technique of weaning when compared to pressure support ventilation or the TP's trial. So why is it so? What could be the cause? Because SIMV can result is an increased work for breathing due to unsupported allowed breaths. Solution to this problem was suggested. And what was the solution? Just add pressure support to the SIMB, spontaneous breath. Add support to spontaneous breath. Here we have added a pressure support to a spontaneous breath, and the tidal volume will go up and the patient will feel less breathless. So that is the advantage of adding the pressure support to SIMB mode. The studies are coming. The SIMB plus pressure support is better than plain SIMB. So this is the example here. We have added a pressure support to the spontaneous breath here to increase the tidal volume of about the same tidal volume which we are giving for the volume control. Here you will recognize the SIMB mode on mechanical ventilation. So there will be assisted time cycle breath, and then there will be flow cycle supported, pressure supported breath. Okay, so this is the time cycle, this is the control breath, and here this is the flow cycle breath, because you can see it is getting cycled earlier above the baseline. So this is the flow cycle breath. After reaching certain flow, the ventilator is cycling the breath. So that is your way of recognizing the spontaneous breath on pressure support on SIMB mode. Now we will discuss the most popular mode of breathing in ICU nowadays, that is called pressure support mode. As we have seen in the previous slides also, that in this mode the patient takes control of its own breathing as far as triggering the ventilator is concerned. So ventilator won't trigger the breath at all. That may result in apnea in few patients. So apnea is a problem. That is why you should have a backup ventilator settings on the mechanical ventilation. In case the patient is not able to trigger the ventilator, the patient will not be harmed. The ventilator will start the backup or apnea ventilation for the patient. Okay. So this is the safety feature provided in the ventilator, and you should always set the backup or apnea ventilation on your now all modern ventilators have this setting on already. Whenever as soon as you put the patient on pressure support mode, these apnea ventilators are automatically set. Okay, the settings you have to actually set, but apnea ventilation mode will be auto on. Okay, nevertheless, the peculiar type of cycling is observed in this mode, and that is called flow cycling. So remember, the trigger will be the patient, limit will be the pressure, and cycling will be the flow. So whenever you are putting the patient on pressure support ventilation, set ATS, that is expiratory trigger sensitivity. Okay, that means that after a certain flow is reached, okay, so the flow will reach to a maximum value and then will start decreasing. So after a certain flow, when it is decreasing, the ventilator will cycle. So that is your proportion of the peak expiratory flow. So usually they are set at 25%. Okay. So whenever the 25% of the peak expiratory flow is reached, the ventilator will cycle off. COPD patient, we increase the ETS. It will cycle early, and which is desirable in COPD because it will give you expanded or increased inspiratory time. So that's all for today. Thank you so much. Module 2 is over. We have discussed basic modes of mechanical ventilation. We have discussed CMV. We have discussed SIMV. We have discussed the pressure support. We have discussed the types of breath, mechanical or machine breath. Then we have discussed the spontaneous breath. We have discussed assisted breath, then supported breath, and we have discussed the phases of inspiratory breath. Okay, so we have discussed the Pplat and P-peak also, and implications of knowing that. So I hope that by understanding the ventilator more and more, you will be able to save more lives in your ICUs. All the best.